Great. Well, certainly want to welcome everybody to this week's happy hour session. We're very pleased to have Dr. Vandergriff hosting today's session. Travis, as you'll remember, is boarded in dermatology and dermatopathology and is a professor in both departments at the University of Texas Southwestern, where he heads up the dermatopathology division. And so, Travis, very pleased to have you. Look forward to what you have to teach us.
Thanks for the introduction, and thanks again for the invitation to participate. And hope everybody got a chance to preview slides. I'm going to share my screen, and I'll kind of scan through the slides and describe what I think are the really the important features to make these diagnoses. Some of the diagnoses today are bread and butter, and then there's a couple of diagnoses that I would consider to be a little bit more difficult and a higher level differential, but we'll kind of go through them individually, and I'm going to start sharing my screen right now. Okay, can y'all see the screen with the slides on it?
Yes, the slides are looking good.
That's looking great, Travis.
Okay, thank you. Okay, so our first diagnosis that we're going to review is a variant of basal cell carcinoma. And so basal cell carcinoma is definitely bread and butter diagnosis in dermatopathology, and hopefully one that you all are able to recognize from not only from studying, but also just routine sign out. We're going to look today at an example that I would describe as micronodular. So basal cell carcinoma, as you know, is the most common type of cancer in humans. And so something we see very commonly, not only in patients, but under the microscope. And it's formed by a proliferation of basaloid epithelial cells. So basaloid basically just means basophilic or purple. So on scanning, you're going to see this purple color, which means that these cells are taking up hematoxylin. And they form nodules. Basal cell carcinoma forms nodules that have peripheral palisading of nuclei. Peripheral palisading means that at the periphery of the nodule, the nuclei are arranged in a way such that their long axis is oriented towards a central point. So here's a peripheral palisade here. This is a common feature across all the different subtypes of basal cell carcinoma. Another common feature in all subtypes of basal cell carcinoma is retraction between tumor and stroma. So there's clefting or retraction between the tumor and the adjacent stroma. The stroma of basal cell carcinoma is fibromyxoid, meaning the stroma has some collagen and fibroblasts, but also some mucin, and that's where the myxoid part of the description comes into play. And mucin, remember, it has a kind of a bluish gray color. So you've got this blue-gray stroma between the tumor strands. And then when the tumor strands or nodules are mostly small, so we're talking about clusters of 5 to 10 cells, this is called a micronodular basal cell carcinoma. Usually in micronodular basal cell carcinoma, you'll find some areas that look more recognizable as just your regular old nodular basal cell, like this guy here. But the predominant morphology is a smaller nodule. They still have that palisaded appearance to the nuclei, it's just that the nodules are smaller. And so this is a basal cell carcinoma, a micronodular type. And this is a little bit higher risk for recurrence and locally aggressive behavior, kind of in the same way that an infiltrative basal cell or a sclerosing basal cell would be. So when we report a basal cell carcinoma, we want to indicate the histological subtype so that the aggressive forms can be treated more appropriately. And micronodular is one of those subtypes. And you basically just see small nodules, cords, and strands of basaloid cells rather than the larger nodules we're used to seeing in the conventional nodular basal cell carcinoma. That's a variant of basal cell called nodular basal cell carcinoma, micronodular basal cell carcinoma. Okay, we're moving on to another subtype of basal cell carcinoma. This one I think is more rare and also a little bit more difficult to diagnose. And this is called Infundibulocystic basal cell carcinoma. So Infundibulocystic basal cell carcinoma is a type of basal cell carcinoma that has more cysts and is more terminally differentiated. So if we go back to that first basal cell, the color that you see on scanning is mostly purple. And that is a basaloid or a more primitive type of epithelial cell. The more basophilic, usually the more primitive the cell is. And as the cells differentiate, one of the processes of a keratinocyte to undergo as it differentiates is keratinization. So once a cell starts making a little bit of keratin, the cytoplasm becomes more pink. And consequently, a more terminally differentiated neoplasm will show a little bit more pink color on scanning. So that's why this version of basal cell carcinoma looks a little bit more pink rather than purple on scanning, and that's because it's more terminally differentiated. So less primitive, more differentiated, and it's differentiated towards the hair follicle. And the reason that we know that is because there's little follicular cysts. So in a infundibulocystic basal cell carcinoma, you have follicular cysts within the tumor. Okay, and they're described as infundibular because they resemble the infundibulum of a hair follicle. So infundibulocystic basal cell carcinoma has cystic structures, which are derived from the infundibulum of a hair follicle. Another architectural feature for infundibulocystic basal cell carcinoma is described as interanastomosing strands. So remember from your med school days, anastomosis is simply just a connection between two structures. And so to describe the epithelium as anastomosing strands basically just means that you have thin strands which connect across little pedicles or bridges. And those are called anastomosing strands. So the architecture for this type of basal cell is described as anastomosing strands. And it's these infundibular cysts that really indicate that this is a more terminally differentiated keratinocytic proliferation. So how do we know that this is still in the category of basal cell carcinoma? Well, you still have some of the features that you expect to see in basal cell carcinoma, such as peripheral palisading of nuclei. So here's an area where we've got peripheral palisading. I see another area here where the long axis of the nuclei are oriented in a way such that they're pointing to a central point within the tumor nodule. That's peripheral palisading of nuclei. And then anytime we're looking at adnexal neoplasms and trying to distinguish them from carcinomas, we really want to look not only at the epithelial part, but also at the stroma. So the epithelial part is the part that's made up of the cells, the keratinocytes. Then the stroma is the intervening connective tissue. And in basal cell carcinoma, like we saw in the first example, the stroma is fibromyxoid. So not super dense with respect to cellularity. So kind of a lower cellularity. And then notice here that there's this myxoid appearance to the stroma, that blue-gray color. That's that fibromyxoid stroma that's typical of a basal cell carcinoma. Here's a good example of the infundibular type of cyst where you've got keratin that basically looks like the same type of keratin you would see in the horned pseudocyst of a seborrheic keratosis, or just the keratin that you would find filling the infundibulum of a follicle. This is where the infundibulocystic name comes from. And then you've got your stroma that's very important for differentiating basal cell from benign follicular neoplasms. And in this case, it's more of a loose fibromyxoid stroma. This is infundibulocystic basal cell carcinoma. Some people describe it or conceptualize it as a well-differentiated form of basal cell. I like to think of it more like a more terminally differentiated form of basal cell, meaning it's really kind of more showing features of recognizable as follicles, whereas a normal basal cell carcinoma is a little bit more primitive and you don't see those follicular structures. And the part of the follicle that you find in this is the infundibula. This is infundibulocystic basal cell carcinoma. Okay, our next case is a kind of a foil to the two previous diagnoses of basal cell carcinoma. And now we're going to talk a little bit about some of the benign adnexal neoplasms that are follicular in origin. And so I kind of think of these and describe them with residents as the trichos. So tricho is a prefix for several different benign neoplasms that you'll encounter in dermatopathology. And tricho simply means that the neoplasm is derived from a follicle. And then there's these different suffixes that sort of specify which follicular neoplasm we are diagnosing. And so you've got trichoepithelioma, you've got trichoblastoma, you've got trichofolliculoma, and the tricho aspect of it simply means derived from a follicle. Now, anytime we're looking at these neoplasms, you always want to start on scanning magnification and just get a sense for architecture. And it can be important not only to help you decide if you think this neoplasm is benign or malignant, but also to get a sense of whether, like if you've decided it's in the tricho family, are you dealing with a trichoep or a trichoblastoma? So on scanning magnification here, I would describe this neoplasm as circumscribed. So easy to tell where the neoplasm starts and stops. It's symmetric, meaning that if I draw a line across the middle and reflect across that axis, it looks pretty similar across that line of reflection. However, this is pretty large. So what you're seeing here is an excision. And just to kind of orient you on the size, you've got your sebaceous lobules and your hair follicles here. And then this tumor is, extends into the subcutis, and you've got this broad span here. So this is large, but otherwise well circumscribed and symmetric. So it has a benign silhouette, but recognizing that it's on the large size. So now we start going in a little bit more higher magnification. And what I'm seeing is that this tumor is formed by small nodules of basaloid epithelial cells. And I'm calling them basaloid because they are basophilic. They are a purple color on scanning magnification. So it's a small nodules of basaloid epithelial cells. And then I always try to follow that observation by commenting or scrutinizing the stroma. So basaloid epithelial cells situated in what kind of stroma? So I want to focus on the stroma. And so I try to force myself to describe the background in which these nodules of epithelial cells are situated. So I would describe these as small nodules of basaloid epithelial cells situated in a cellular and fibrotic stroma. So this is a really important point for distinguishing your benign follicular neoplasms, your trichos, from a basal cell. The stroma is very different. So the stroma in a basal cell carcinoma we described as fibromyxoid. It's kind of loose, it's pale, it's got a bluish color due to mucin, and it's got low cellularity. In contrast, the stroma of a trichoblastoma or a trichoepithelioma is more dense and more cellular. And it's collagenous, so it's going to have this pink color rather than blue. So as I look at the stroma here, I see dense collagen bundles. I see fibroblasts or spindle cells that are increased in number. And then I also see that that there's no retraction between the tumor and stroma. So that's another element that we want to look for in distinguishing basal cell carcinoma from trichoblastoma, is whether or not there's retraction between tumor and stroma. If we find that, it's a feature that's more consistent with basal cell. And in trichoblastoma or trichoepithelioma, the retractions are actually stroma to stroma. So I see a little cleft here. It's not between the tumor and the stroma, it's actually between little strands of collagen. So stroma to stroma clefts, which would be the typical pattern in trichoblastoma, which that's what this is a trichoblastoma. So we've got our basaloid epithelial cells arranged as nodules situated within a cellular and fibrotic stroma. There are stroma to stroma clefts, but not tumor to stroma. So here's another stroma cleft. And then the hallmark finding that you really kind of want to hunt for and find in basal cell, in trichoepithelioma and trichoblastoma is called a papillary mesenchymal body. And here's a good example of a papillary mesenchymal body. A papillary mesenchymal body is a primitive hair follicle. So it loosely resembles the base of a follicle where a hair bulb is in development. So this is a primitive hair germ or primitive hair structure. It's called a papillary mesenchymal body. And I always kind of think of it as looking like a cup that's formed by epithelial cells. So you have this cup-shaped proliferation of epithelial cells. And then within that cup, you have a cluster of small, loosely organized mesenchymal cells. And so it's sort of like a cup, and then you've got some grapes or some berries in that cup. And what's inside the cup is kind of loose and not organized very well. And then around it is this more organized epithelial proliferation. That is a papillary mesenchymal body. So trichoblastoma is a large lesion. It is formed by basaloid epithelial cells arranged in nodules, situated in a cellular and fibrotic stroma. And you will find papillary mesenchymal bodies. So this is a trichoblastoma. Now we're going to go on to another tricho, which is similar, but has some important differences. And this is trichoepithelioma. So one of the big differences that you'll notice on scanning is a difference in size. Trichoblastoma is large, trichoepithelioma is small. And when I say small, I'm usually talking about, a couple of millimeters, 2 or 3 millimeters, 4 millimeters, the type of thing that clinically you might consider a diagnosis of sebaceous hyperplasia or a fibrous papule. A trichoblastoma, you're usually thinking more along the lines of a cyst or a larger tumor, something like the size of a grape. So trichoep is smaller than trichoblastoma. Trichoepithelioma is also more differentiated towards the follicle. And you'll see infundibular structures, whereas trichoblastoma is a little bit more primitive. So blast, that suffix implies a primitive state. And so for that reason, in a trichoblastoma, pretty much all you see are the primitive cells, the basaloid epithelial cells and the papillary mesenchymal bodies. But you don't see follicular cysts with keratinization inside the cysts. In a trichoep, however, you will see some of those follicular cysts with infundibular keratinization. And that indicates a little bit more terminally differentiated or less primitive type of differentiation here. So what we see in a trichoep is overall a small lesion. It is formed by basaloid epithelial cells. Those basaloid epithelial cells form nodules, and the nodules are situated in a cellular and fibrotic stroma. So just like in trichoblastoma, trichoepithelioma has a stroma that is dense, collagenous, and cellular. And this is in contrast to the stroma of a basal cell carcinoma. So you have a dense, collagenous stroma. Now it's important to kind of remember that trichoep and trichoblastoma can have peripheral palisading of nuclei. So notice that there's peripheral palisading of nuclei here. That particular feature should not be overemphasized as specific to basal cell carcinoma. That feature is shared between basal cell and trichoep or trichoblastoma. So the peripheral palisading can help you distinguish a basal cell, for example, from actinic keratosis or a squamous cell. But if your differential is basal cell versus trichoep, don't rely on peripheral palisading as a distinguishing feature. Look at the stroma. It's going to be more cellular and dense in a trichoep. You have retraction from stroma to stroma in a trichoepithelioma, just like you do in a trichoblastoma. But there's no retraction between tumor and stroma in a trichoep. Just like a trichoblastoma will have papillary mesenchymal bodies, you can expect to find those in a trichoepithelioma as well. So this is a good example of what a papillary mesenchymal body looks like. You have this cup of epithelium. Here's your little cup-shaped proliferation of epithelium, and then within that cup is a cluster of loosely organized primitive mesenchymal cells. This is like the hair papilla. If you go back and look at this normal hair anatomy, this is recapitulating the papilla of the hair. In trichoepithelioma, you often find little follicular cysts. So you'll see these infundibular cysts, which just simply represent that it's a little bit more terminally differentiated. And again, the stroma is more cellular and fibrotic. So this is a trichoepithelioma. And if you're reading about trichoeps, you might see some comments about the immunohistochemistry that can be used to differentiate them. And I want to just sort of describe what you could find. Generally speaking, I don't think that immunohistochemical stains are necessary or a huge part of the workup for these, but in rare instances, especially in small samples, they can be helpful to make your differential diagnosis. And so the stains to know about for basal cell versus trichoep or trichoblastoma are CK20, BCL2, and CD10. So CD10 is going to stain the papillary mesenchymal bodies and the fibroblasts in the stroma of trichoeps and trichoblastomas. So CD10 would be positive in that cellular and fibrotic stroma and in papillary mesenchymal bodies like this here. CK20 highlights scattered Merkel cells within benign lesions. I have a photo that I want to show here. So here's a trichoepithelioma, and you can see the papillary mesenchymal body there. A CK20 stain will highlight just scattered cells within the tumor. Those are actually Merkel cells. It's not a neoplasm of Merkel cells, just normal scattered cells. And in a basal cell, you would expect to not find any of those. So CK20 positive cells in a trichoep. And then the other stain that we sometimes use is called BCL2. So BCL2 will be positive really only in the periphery of the tumor in a trichoep and is negative in the center in a trichoep. Whereas in a basal cell, it kind of stains the whole tumor. So BCL2 is another stain that we sometimes use. I don't think stains are critical for the diagnosis, though. Okay, moving on to another variant of Trichoepithelioma. This is a Desmoplastic trichoep. So this one's a little bit different from the conventional or traditional trichoepithelioma because the tumor strands, instead of being small nodules, are really like thin cords and strands. So, like I mentioned earlier, it's really important on scanning magnification to get a sense of the architecture, especially the circumscription and the depth to which the lesion extends. So notice that this is a superficially situated neoplasm that is circumscribed. It does not extend deep into the dermis. In fact, it really appears to be limited to the papillary dermis and maybe a little going into the reticular dermis, but not into the subcutis. So it's superficially situated. As we go in on higher magnification, I can see that we're dealing with a neoplasm that is epithelial, and it's arranged as thin cords and strands. So not nodules, but thin cords and strands, situated in a cellular and fibrotic stroma. Okay, so you've got your cellular and fibrotic stroma, and the strands are very narrow. Notice also that we have some infundibular cysts, or little small cystic structures, which indicate that more terminal differentiation. That's typical of Desmoplastic trichoepithelioma. And then another feature which is really helpful to find are microcalcifications. So this is an example here of calcification. So little small punctate microscopic calcifications are a good feature for diagnosing Desmoplastic trichoepithelioma. So it's important to distinguish this from a basal cell carcinoma, which would have more retraction between tumor and stroma, and a stroma that's more loose and mucinous rather than cellular and fibrotic. And then we're going to look a little bit later at microcystic adnexal carcinoma, which is also on the differential, but extends way deeper. So a lot deeper into the reticular dermis. It's not circumscribed and small. And these follicular cysts that have keratin in them, that's kind of shaped like concentric rings, this helps you recognize it as a follicular neoplasm rather than a sweat gland neoplasm. So the presence of these little follicular cysts helps you get it into the category of a follicular or pilar neoplasm. So that's how you know that this is in your tricho differential. This is Desmoplastic trichoepithelioma. Okay, moving on. We're still in the epithelial neoplasm differential. This one is a syringoma. Okay, so syringoma is, on scanning magnification, a small dome-shaped papule that is going to be very well circumscribed. So just like we did with our other neoplasms, we want to start on scanning magnification by getting a sense of how large is the lesion, how deep does it extend, and then how sharply circumscribed is it. And generally speaking, for benign neoplasms, sharp circumscription is the architecture. So I'm seeing this sharply circumscribed neoplasm. The neoplasm in this case is epithelial, and I would describe these epithelial cells as arranged not only as strands, but also as ducts. So this is kind of the most salient feature here, is recognizing that we have ducts situated in the dermis. And many of those ducts have a little tail of epithelium that comes off from the side. So they're shaped kind of like commas. And you've got this little tail of epithelium to the side. So this is a syringoma, and these ducts represent eccrine sweat glands. So this is a common scenario where you see these little cysts or ducts, and you're trying to decide, okay, is that pilar? Is that a cyst? Or is that eccrine? Is that a duct? And so one thing that you can do is kind of look at the contents of what's in the lumen. And in a cyst, remember, we saw concentric rings of keratin. In a duct, you're going to see more of a spongy gray material that's not really organized in a concentric ring. It's more like just loose and got this sort of spongy appearance. And it's got more gray color than pink. That's eccrine sweat. Here's a good example of it here. Okay, the eccrine ducts also have a little bit more clear cytoplasm. So here's an eccrine duct. It's got that gray spongy material. Then you've got this layer of cuboidal cells around it with a little bit more pale or clear cytoplasm here. So that is typical of eccrine differentiation. So you've got eccrine ducts with these little tails of epithelium situated in a cellular and collagenous stroma. So that is a syringoma, which is a benign neoplasm derived from the eccrine duct. The main differential here, I think, would be with your pilar neoplasms like Trichoepithelioma, Desmoplastic Trichoepithelioma. And it can be very helpful to try to decide if you're dealing with a sweat gland neoplasm or a follicular neoplasm by looking at the contents of the little structures which have an empty space in them and deciding, is that a duct or is that a follicular cyst? Okay, so we've been talking about pilar neoplasms and eccrine neoplasms, and now we're going to talk about a neoplasm that actually has features of both. This is a microcystic adnexal carcinoma. Microcystic adnexal carcinoma. It's called adnexal rather than follicular or eccrine because it actually has differentiation towards both types of adnexy, towards the follicle and towards the eccrine sweat gland. So that's why it's called microcystic adnexal carcinoma. In the superficial part of the tumor, you've got a little bit more of a follicular appearance, and then in the deeper half, more of an eccrine appearance. We're on scanning magnification here, and we have a punch biopsy, which reveals this tumor to be deeply situated and also just extending deeply. So this is a punch biopsy, and the tumor goes all the way to the base of the punch, and also side to side. So you can't comment or make any observations about architecture here. We don't know how large it is. We don't know if it's well circumscribed or not. We don't know if it's symmetric. So you're starting from a baseline where you're more suspicious on scanning, and that's due to the architecture here. As I go on a higher magnification, I can see that we're dealing with an epithelial neoplasm. The neoplasm is arranged as cords and strands of cells, so thin cords and strands of cells. The stroma is sclerotic or dense and collagenous. If I go to this, and I already kind of made the observation that it extends deep. So I'm going to start at the surface, and I'm looking at the surface aspect of this, and this is where I'll find more follicular type of differentiation, some of those concentric rings of pink keratin. As I move towards the deeper aspect of this neoplasm, I start to see more of an eccrine ductal pattern. So I start to see these small ducts that look more like eccrine differentiation. Sometimes you'll even see that that spongy gray sweat material inside the lumen. So there's a kind of a transition, superficially resembling follicular and then deeply resembling eccrine. Cords and strands of tumor cells situated in a sclerotic stroma. And microcystic adnexal carcinoma classically will have perineural invasion. So this is a tumor that shows perineural invasion very frequently. So it's helpful to identify that. Here's a nerve. Okay, so I'm gonna trace the outline of a nerve. It's cut in cross section across its short axis. And then you've got tumor cells surrounding that nerve. That's perineural invasion. And this is a very typical feature of microcystic adnexal carcinoma. So it's large, it extends deep, it has follicular differentiation up top, it has eccrine differentiation down at the bottom, and it will have perineural invasion. Okay, another adnexal tumor, and also one that is prone to perineural invasion. This is called adenoid cystic carcinoma. Adenoid cystic carcinoma, so notice how large it is. You've got a very large tumor, asymmetric, it looks like it's kind of bottom heavy here. Adenoid cystic carcinoma is basaloid or basophilic, so the tumor is going to appear kind of purple on scanning. And it has an architecture that's described as cribriform. And cribriform simply means perforated by small holes. So you've got a tumor which has tons of little holes punched into it. Within those holes, you will find mucin. And the mucin is going to be kind of granular and blue. So you've got this granular blue mucinous material present within tiny holes that have been punched into the tumor. It kind of creates this Swiss cheese appearance. So you've got mucinous deposition within holes that are perforating this basaloid epithelial neoplasm that's usually arranged as nodules. Okay, so tons of tiny little holes, and they've got mucin in their stroma and within those holes themselves. So finding the mucin is an important feature. Adenoid cystic carcinoma, like microcystic adnexal carcinoma, often has perineural invasion. I didn't see a good example of that here on this slide, but adenoid cystic will have perineural invasion as well. Okay, so now we are moving out of the adnexal tumor category into kind of a little bit more of a mixed bag here. The diagnosis for this next slide, number 9, is crusted scabies. And crusted scabies is a variant of scabies in which the number of mites in the cornified layer is a lot higher than your typical presentation of scabies. So in a normal presentation of scabies, the patient may have like 10 to 12 mites on them. In crusted scabies, it can be literally hundreds. Okay, somebody's raising their hand. Is there a question? Okay, maybe put it in the chat or something. Okay, so we've got this proliferation of epithelium here, which makes the epithelium look acanthotic. So you've got this acanthotic epidermis, and also notice how hyperkeratotic it is. You've got this really crazy hyperkeratotic cornified layer. And on scanning magnification, it looks a little bit like, almost like a neoplasm. You're concerned at least about that on scanning. As you go to higher magnification, though, you can see that this epithelial proliferation, this acanthosis, is benign. It's got the nuclei are small. There's lots of cytoplasm, and the cells per unit area is low. So this would be described as pseudoepitheliomatous hyperplasia. And when you've got hyperkeratosis plus pseudoepitheliomatous hyperplasia, you want to think about a prurigo nodule. So prurigo nodule, or even plaque of lichen simplex chronicus. And then what's kind of conspicuous here is in the cornified material, you've got mites. And the mites are pretty numerous here. So normally in scabies, you might find one mite in the cornified layer. Here we've got two just within that little field of view. And then you'll see what are called pigtail structures. So pigtails are these little curly pink spirals, and they represent fragments of eggshell that have kind of coiled, and they are scabies mite remnants. So it's shells from the eggs that the mites came out of. It's a remnant of that. So it's equally as diagnostic as finding the mite itself. So we've got tons of mites. We've got the pigtail structures, which represent eggshells, and then you've got the underlying Micronodularis features. So crusted scabies, patients have thousands of mites on them at any one time, and it creates this hyperkeratosis that's extreme. And so here's another example of some of those nice pigtails or spirals that are typical of scabies. I think of scabies as a microscopic ectoparasite. So microscopic means I can't see it with my naked eye. I have to get out a microscope and do either a biopsy or a scraping, and then I can see the mite under the microscope. Ectoparasite means it lives on the surface, but does not penetrate beyond the skin. So scabies is a microscopic ectoparasite. Contrast that with Tungiasis, which is a macroscopic ectoparasite, meaning I can see the flea here, the sand flea, with the naked eye. It creates a punctum in the acral skin where it burrows, and you can actually see the mite, or the flea is big enough to see with the naked eye. So Tungiasis I put kind of on my differential for macroscopic ectoparasites. And the distinguishing features for Tungiasis really have to do first with the location. So this is really an important observation to make, is where are we anatomically? And for Tungiasis, remember the way that you contract the disease is by stepping on the sand at the beach where the sand flea lives. And so it's usually on the bottom of the foot. And so hence you're going to find that the biopsy site shows an acral profile. You've got a thick cornified layer. You've got hypergranulosis, and you've got acanthosis. So that's the overall kind of situation, is that we're on acral skin. And then burrowed within that acral skin is your flea, your organism. And it's usually situated kind of under a thin shell of cornified material, and it penetrates down into the granular cell layer. That's really as far as it goes. It doesn't go down into the dermis. Looking at the flea a little bit more closely, you're going to see all the anatomical structures that you would expect to find within an animal. So it's going to have muscle. Here's skeletal muscle bundles. You can see the little striations there. It has a gut, which is filled with blood in this case. It's these things here. There's respiratory epithelium. And you've got this chitinous exoskeleton. So the exoskeleton has this smooth pink profile. It's like a shell. So I worry less about, when I'm trying to distinguish this from myiasis, for example, or scabies, I worry less about what's on the inside than I do where is it located. And it's important to recognize Tungiasis being on acral skin. And then also Tungiasis, while the outer exoskeleton can be kind of spiky, like a little bit spiny, it does not have the hooks or the pigmented spines that you see in myiasis. Those little orange spines or hooks that you see in myiasis, you will not find in Tungiasis. This is Tungiasis. Okay. Next one is interstitial granulomatous dermatitis. So this is a punch biopsy, and on scanning magnification, you can see that what we're dealing with here is a dermal-based infiltrate. So the pathology is situated in the dermis. Also notice that on scanning, the infiltrate is kind of pale. It's not dark blue like lymphocytes. It's got a little bit more pallor to it, which suggests histiocytes. As I go in on higher magnification, I can see that these truly are histiocytes. They are epithelioid cells, meaning they have a round to oval nucleus and abundant cytoplasm. And that cytoplasm is pale. So these are histiocytes. And sometimes you can find multinucleated cells that really help you confirm that it is a histiocytic infiltrate. So that can be helpful to find multinucleated cells, but not required. When histiocytes are the predominant inflammatory cell type, we call that granulomatous. So if you wanted to define the word granulomatous in a very simple sentence, you would just say histiocytes predominate. And after you've identified a granulomatous infiltrate, you kind of want to decide how are they organized or how are they arranged. And in this example, the histiocytes are present between collagen bundles in little strands and what's called a rosette, which is where they surround collagen bundles, like this. They're kind of surrounding and even dissecting out collagen bundles. That's called a rosette. So it's between collagen bundles, between and around collagen bundles. That's called an interstitial pattern. So this is the interstitial granulomatous dermatitis. Notice that we have some eosinophils mixed in. That's normal and okay in this diagnosis. There is a little bit of mucin here. So if you look at the stroma, you're going to see some granular blue-gray material in the stroma, which is mucin. So the main differential here would be interstitial granuloma annulare. So granuloma annulare has the palisaded type and the interstitial type. And that would be the main differential here. Interstitial granulomatous dermatitis, sometimes called interstitial granulomatous dermatitis with arthritis, is a granulomatous eruption that occurs in the setting of connective tissue diseases. And it closely resembles granuloma annulare with a few distinctions. One of them being the mucin is a little bit less prominent in the IGD or interstitial granulomatous dermatitis and more prominent in GA. The other feature that's described as being more specific for IGD is this rosette formation where the collagen bundles are like tightly surrounded by histiocytes. So those are two features that you can kind of look for to help you distinguish. But I think the bottom line is for these diagnoses, it's really important to think about the clinical setting. And does the patient have arthritis? Does the patient have any features that are suggestive of a connective tissue disease? Or is this simply some pink patches on the flanks in an otherwise normal person? You might diagnose that as interstitial GA. Okay, so our last case, this is truly a zebra, and one that I have never personally diagnosed, but is kind of a cool diagnosis and one that I don't think is, I think it's a little bit of a rarity, so don't feel bad if you didn't recognize this immediately. So this is oxalosis, cutaneous oxalosis. And what I see on scanning magnification is just a super dense inflammatory infiltrate in the dermis. I also see that there's some epidermal detachment and necrosis. And then I also have, my eye catches these pale structures here, which look to be kind of like these acellular pale nodules situated deep. So I'm definitely going to want to go look at those and key in on those. But just kind of looking at the overlying epidermis, you have epidermal necrosis and detachment. That is a consequence of ischemia. So some of the vessels in oxalosis become thrombosed due to the inflammation and the crystal deposition. And then you've got this mixed infiltrate in the dermis, which has some histiocytes and lymphocytes. And it's the crystals that really stand out. So oxalosis is it's a genetic disorder where patients have a mutation that prevents their efficient metabolism of oxalate. And they get hyperoxalosis. It leads to kidney stones and kidney failure. And the oxalate crystals can deposit in the skin and lead to tissue necrosis. So it's recognizing the crystals that really is the key to diagnosing oxalosis. And the crystals of oxalate are described as rhomboids. So they're shaped kind of like a polygon that's a rectangle or maybe a square or a rectangle that's tilted a little bit on an axis. But you've got these polygonal crystals. They're elongated rhomboid shaped crystals. They are refractile. So if you had the benefit of having a microscope and you had the little fine focus knob and turned it up and down a little bit, you would see that the light bounces off of them. That's called refractile. And they have a yellowish color. So the crystals are deposited in the dermis and then they're surrounded by an inflammatory infiltrate, which is usually mostly histiocytes. This is cutaneous oxalosis. It's a rare diagnosis. It's in patients with a genetic predisposition, which impairs the metabolism of oxalate crystals. So not something you'd expect to see very commonly, but certainly certainly has a unique appearance microscopically. That's oxalosis. That is the end of our session here. I think if there's any questions, I'd be happy to answer those. You can send me an email or put them in the chat bar. I don't see any questions there. But thanks for tuning in, and I hope everybody learned a little bit, and hopefully we'll get to see you again some other time. Thank you.